All right. Well, good afternoon, I guess it is now. And it's interesting because we've had a lot of discussions about federated learning so far, and you might be like, well, he's going to come up and talk about something really advanced. But actually, you heard the best people already. So I'm going to talk about, from more of a kind of global standpoint, um, what is it that we're actually looking to achieve, and how is AI going to fit into this plan? And what kind of stake has I2B2 made in this environment? As I think you've really kind of been able to appreciate, we are really concerned about lowering barriers to accessing EHR data. That is the principal reason that I2B2 exists. And it's not just to get it to more people, it's to get it to people who aren't informatics experts. Because people who do clinical research and know the most about medicine and so forth aren't necessarily going to be the most acclimated in informatics. So really, the folks who could make the best use of I2B2 are not the informatics people who are building I2B2. And therefore, that's why we have this emphasis of investing in these tools, and Griffin has just shown you the next generation there. We also have an open source approach, because that way new additions can be made, and when new technologies like large language models come in, we can add those as well. But again, we're not necessarily going to be the ones who know exactly how to do all that. So relying on the community as a whole to be able to help with that is what we do. And for example, we're not the best ontologists in the world. We don't know the most about like how to deal with medical vocabularies and so forth. But we know somebody who is, and it's Michelle Morris. Where'd she go? There she is. So, from Pittsburgh. All right. So therefore, we have the ability to go and really understand from her how to do it the best, right? So that's the kind of point of why we take this approach. Now, we have this community website, community.i2b2.org, which everyone can go to now. You can also, by the way, go to www.i2b2.org, which is where we distribute the I2B2 software. And you can actually do the demo of that exact client that I showed you just a minute ago. Now, here we really try to emphasize where we're going with the data. And the bottom line is that I2B2 is a platform to integrate data, real-world data, and data that's collected on our patients together. And if you think about it, there's lots of different kinds of data out there. Electronic healthcare record data is just one component of it. The other component is data that's collected directly during a clinical trial, or that's collected as outcomes from our patients. And this kind of data is just as important and often more valid than what we see in the electronic medical record data that gets collected through our clinicians, who might have a kind of bent on it that our patients don't actually have. And then, of course, there's all the other ancillary data, genomics and imaging and medical biomed data, which is the kind of generic name we give to all that EKG and ECG and all that kind of things we collect while patients are in the ICU or through Fitbits and so forth, and put that all together and have a data model that supports all of that. Right? And that's what we have in this I2B2 approach. We also have this modular pattern that we build the software in that allows us to add these new plugins that people put together. And that, again, is what Griffin was showing you, is how we could add those into I2B2 and make a great or greater I2B2. Although, frankly, using the word great has lost its appeal lately, but nonetheless, okay. We can build specialized research portals. So, for example, at Mass General Brigham, there's a very specialized biobank portal that offers a genomic data interface so that you can actually query the genomic data, find patients with a specific variant. And then during COVID, we had a causal inference portal that let people use data that we collected from COVID in various places to actually formulate questions about COVID and so forth. And we ended up creating an enclave just during COVID that we had many thousands of people at Mass General Brigham using to answer questions about COVID. And fortunately, we've had I2B2 adopted in many different hospitals across the globe. And therefore, we have been able to leverage, kind of like in this meeting, the knowledge and willpower, I should say, of many, many groups to build this data network. But the bottom line is, in the last few decades, I guess, we have become invested in solving the following problem, which is claims data, which is used for 95% of real-world data analyses, whether it be for research or whether it be for your latest statistics that you see on television about how many people have diabetes, are critically flawed. And as I think you've seen at various times and was explained in excruciatingly detail by Tianqi, when we go and look at who actually has a diagnosis of, for example, diabetes in the claims data, and whether they really do have diabetes, it turns out that only about 50% of the people have diabetes. Now, why is that? Are they just, do doctors not know how to classify their patients? And the answer is no. They're doing it exactly the way that Medicare is telling them to do it, which is you give a person a diagnosis code, ICD code of diabetes, when you get a test ordered for diabetes. You must, otherwise they won't pay for the test. The bottom line is these codes are not being used for research, right? That's not what their intention is. We're using stuff that's being collected in the real world, but it wasn't collected to do research. It was collected for something else. And therefore, when we want to use it, we need to clean it up. And so how do we go about doing that? Well, so we've seen that one of the methods was these rule-based methods. You can say, well, maybe they can have 2 codes for diabetes, or maybe 5, and so forth. And there's trade-offs for that. And you can use AI-based methods, which Griffin and Tianqi showed. And those do turn out to be very adaptable to many different hospitals when they implement them. And therefore, this approach can scale well and be a new face for the country and internationally for data that gets collected to express what different diseases, and it extends way beyond diseases. It can be any medical condition. How many people have that medical condition can be shown And now we can get into data that's accurate enough to be used for research. Of course, that doesn't mean that we only would want to use it for research. Public health reporting seems like it would have the same problem. If you think about it, what you realize is that what they report as how many people have diabetes in the country, it must be twice as many as actually do, right? You would think that would be a crisis, but all right. So I2B2 gives us a mechanism to get to the truth. Now, the problem is that it can be quite complex to implement some of these methods, and therefore we need the data set up in ways that we can host in I2B2. So it's actually a tractable problem, right? But ultimately it does result in a yes-no decision about whether people have a diagnosis, and the best yes-no decision that we can possibly get out of our AI approaches. However, at different hospitals, they leverage different strengths. So you need the data to form these co-occurrence matrices in order to understand and triangulate who has what diseases. But if you don't have many patients with a certain kind of medical condition, you're not going to be able to get a very good co-occurrence matrix on them. And so as a result, you're going to have a lot of kind of air or noise or overfitting or whatever you want to call it in that area. So for example, Mass General Brigham's got massive number of patients, but you know what? They don't have very many pediatric patients. In fact, they have very few. And so pediatric data, which seems like it should be really important, and we should focus on that, we can't really, because we can't really get enough pediatric data together at Mass General Brigham to look into lots of the really important pediatric diseases. But Children's Hospital has lots of pediatric patients. They don't have many adult patients. So what to do? So when you create these co-occurrence matrices, you can put in the data that you have and kind of what is it that's important at your hospital. And sometimes it's really important stuff. Other times it's kind of a red herring, like the mouthwash, right, that we had on a lot of our acute COVID patients, because that's what we got in the ICU. And that is kind of how data gets collected, right? There's no purpose associated for why somebody has the co-occurrence with another item. So what you need to do is you need to combine the data, right, from various places. So if we combine the data that is at MGB and doesn't have any children with the data at Children's Hospital that has the children but not really that many adults, we get the best matrix. And we can do it for lots. So here in hospital, I need my glasses to know my numbers here. 3 and 2, right? Those might be MGB and Children's. And so what we do is we collect children's diabetes and adults' diabetes, so to speak. Children's diabetes might focus more on obesity. Adults' diabetes might focus more on bariatric surgery, for example. And then we combine the co-occurrence matrices, like Tianqi was talking about, and we form a matrix, a super matrix. Now we can then go to hospitals that might not have enough data, and they talked about a data floor, to do their own co-occurrence matrices, but they can add to co-occurrence matrices. A psychiatric hospital, for example, a small psychiatric hospital, or a small community hospital. And then they can learn again by generating these matrices, and give it a little time to generate the matrices. And then putting that data back together. And so in this way, right, all of the hospitals, even internationally, because we're not sharing protected health information, right, it's a co-occurrence matrix. Now, I will note that it's not completely benign to share a co-occurrence matrix if you have rare diseases and so forth. So we need small cell size respect and so forth to understand where to draw the limits on some of this, and it gets a little complicated, I will tell you. But the bottom line is the learning that you can do can now be spread across the nation. And we'll finally actually know through, and this is the real co-occurrence. Those were just simulated co-occurrence matrices that I had there a minute ago. This is the real one, right, for diabetes. It's very complicated. But we get the real co-occurrence matrix. Now we can actually focus on how many people in the United States actually have diabetes. And we can do this for thousands of different medical conditions, thousands, because this is a machine learning process, and it's all embedded in these co-occurrence matrices. So that's basically the message, is by expanding I2B2 and allowing it to actually do this federated learning process, we can get a much more accurate assessment on many different conditions, many different specialties across the country, and use it for scientific purposes, which is what we really invested in to begin with, very invested in our clinical trials in the I2B2 matrix. But the bottom line is it can actually be used for all kinds of public health, and we always keep that in mind. So, okay, thank you very much.
We might have time for a couple of questions if there's any in the room. If you do, please come to the microphone.
Thank you. I have a question for the future development of I2B2 integrating with other databases. Like NCBI, they have a lot of multi-omics data sets, but not patients, animal models. So how can we build tools, bridge tools to link I2B2 patient data sets with NCBI genomics multi-omics data sets? So we can use the transfer learning or representative learning methods to map omics data sets insights into patient stratification and future clinical trial, and also the causal relationship analysis.
That's a great question. So the question is, how do we integrate with the knowledge we have about our patients, the knowledge that we have about genomics and so forth? Now, in I2B2, it's very, very patient-centric. The facts are all about a patient. And the knowledge about genomics, we call it metadata. It's interesting because it's the opposite with radiology, but anyway. So the metadata is critical in managing all of kind of where we have the queries, kind of knowing how to organize the patients in a query is all determined really by the metadata behind it, which tells us kind of what categories to put our patients in and so forth. So at the end of the day, many problems with the metadata become almost as difficult or more difficult than the problem we have querying our patients. And so developing that is an enormous part of I2B2 and kind of an unsung part. And I should say but ultimately we do have to link it to patients for it to be relevant. So, knowing what variants the patient has lets us know what groupings of variants are going to be important to do protein modifications, for example, which then might result in them having a certain kind of medical condition resulting from the loss of that protein. So you kind of go through this process of understanding the metadata in order to really acknowledge the importance of the results from your patients. Now, we are using large language models to organize a lot of that. So a lot of kind of going into, we'll put the study data in with a large language model to help us ask questions, is really trying to get to what you're talking about. And even more broadly, so that we can put in all kinds of different study data and then organize the results around our patients on that.
Thank you.
Hi. I have two questions. First, I think in the morning somebody mentioned about collaboration with Epic. So one thing, first question is around, like Epic has a Cosmos database that's currently with the participants over 300 million patients, I believe. So is the collaboration like involving using Cosmos on top of, or basically combining the two? Because if that can be done, that's a great achievement.
Let me just say one thing before, and then I'll let you. So we are going to have a debate
Okay,
about kind of the merits of different approaches. So that's going to be just hold for that.
okay.
I will note that, I mean, about 75% of our data comes from Epic. Right?
That's, okay.
I think maybe or this morning Zach was talking about a project involving
Right.
Epic and Cosmos. That's a different thing than what we're talking about here in I2B2. I guess the debate will go into more of that. A lot of us are involved in multiple projects. So I'm doing Cosmos for a lot of the work that I'm doing, as well as Federated Networks from MassCPR and other projects. So it isn't so much that we are a federated person or a centralized person. It's more that different kinds of research projects are more appropriate for one database or in others, but they'll be discussed more.
Okay. Yeah, actually, second question kind of related, since you just said 75% data come from Epic. So that really leads to another question. Since I work in the COVID space and been working with different healthcare organizations, Epic obviously dominant in the big integrated health system space. But so I'm wondering with any of the approach, there's bias because we don't really get data from smaller practices, community health centers, which usually they don't have the capability to share their data, I guess.
One thing we mentioned earlier today was the 4C network, our COVID consortium, which was international, and a lot of the U.S. had Epic, but there were a lot of other data models and electronic health records used internationally, and there was biases and uncertainty in what your healthcare system looks like. Was a really big part of 4C. So looking at not only different patient populations, but different countries and different healthcare systems was really important for us to understand what was kind of real, what could we trust versus what might be something unique about a billing system with an institution or a country, or the particular types of care that they give to those patients. That's kind of a little bit the opposite of what you're asking for, but it's the same kind of thing where if you're only looking at your institution, you don't really understand how representative that is of other types of healthcare systems and electronic health records and patient populations.
Right. Yeah, I'm just concerned about like, organizations start using the data for research purpose, then there's, systematically there's some bias of it.
So there definitely is, by the way, and just, it's not only community and sites that use Epic. If you've seen one Epic, you've seen one Epic. So different hospitals use Epic quite differently.
Right.
And so, the fact that they combine, and I guess this is for the debate, but all their data into one big Cosmos database, you'd think, oh, that means it's all the same and combine. No. And so it kind of really loses a lot of its value when you take it out of the local hospital and you put it into some, anyway, we'll debate about that.
Yeah. Okay. Thank you.